Welcome. My name is Gerard Silvestri, and I'd like to welcome you to this webinar on small cell lung cancer. I like to think of it as the forgotten lung cancer because it's become less and less prevalent in the United States. Today, we're going to get an update on limited stage non-small cell lung cancer, and later on, we're going to do one on extensive stage small cell lung cancer. Excuse me. Today, I'm going to be moderating our speakers, Dr. Adam Fox, Assistant Professor of Medicine from MUSC. Mariam Alexander, also an assistant professor from MUSC, and Anurag Singh, professor of radiation oncology at the Roswell Park Cancer Center. And this is our panel for today. I'm going to be turning it over to Dr. Adam Fox, who's going to take us a bit through the epidemiology and the changing spectrum of limited stage small cell lung cancer. Welcome, Dr. Fox.
Hey, thanks, Gerard. Thanks so much for having me and everyone who's on for their attention. I'd like to start with a case here. This is a 70-year-old woman that we saw in our cancer center. She presented with a hilar mass that was found on a lung cancer screening CT. You can see in this picture a pretty central large tumor here. She actively smokes about a pack per day and has a 40-pack year smoking history. And she really presented with no symptoms. She just has mild dyspnea from COPD that's unchanged over years. Next slide. A week after her presentation, she had this PET scan. You can see that the mass is quite avid, and this is just a representative slice, but there was no other hypermetabolic foci on this scan. No concern for other sites. And at this point, the patient did seek a second opinion at our cancer center, and that's what led to a slight delay. Next slide. About a month later, she was evaluated and had a repeat scan. And you can see the difference in size over just 1 month in this tumor. It's pretty impressive for 1 month. Next slide. So that brings us to some of the background that I wanted to cover, which is the presenting characteristics for small cell lung cancer. Many patients do present with symptoms, and this is generally due to the burden of tumor that is common in small cell lung cancer. So there's enough either impinging airways or enough disease in the chest to cause dyspnea, cough, chest pain, or weight loss. And then there's also less common causes like hoarseness from involvement of the laryngeal nerve or diffuse bony pain from metastasis. But radiographically, there's a couple other characteristic clues that are even highlighted by this case. Most patients in one study, an estimate of about 90%, so almost all patients have pretty central tumors. Most patients also present with bulky mediastinal disease. And of course, most patients present with extensive stage or extensive involvement. And then highlighted by this case is the growth pattern. You can see these two estimates in the last two bullets of the volume doubling times for either non-small cell lung cancer or small cell from these two studies. And you can see how dramatically different they are from doubling time of near a year versus doubling time of only 61 days. And so this growth that we saw over 1 month really clued me and should clue people into, hey, this could be small cell. And if it's not, it's certainly something aggressive. Next slide. There's also a strong association with smoking in the US a population about 95%. So almost everyone has a history of tobacco use. But there are some caveats to note. Rarely, but it can happen, adenocarcinoma can present with a combined small cell histology at presentation or de novo without anything else happening. And then we can also see transformation of non-small cell lung cancer to small cell in a few instances. And the one most talked about in the literature is in response to therapy, such as an EGFR tyrosine kinase inhibitor. So if you see someone who maybe initially responded or was recently on treatment and had a really rapid change for worsening or progression, you might think about whether this could be a small cell transformation. And then there's one last caveat, and I think this caveat is related to these first two bullet points here, in that in Asian populations, we do see a little bit higher proportion of patients with small cell and no smoking. And they also, of course, or maybe some don't know, they do have a higher proportion of adenocarcinoma histology in their lung cancer population and a higher proportion of EGFR mutations in their population. Next slide. So to get a little bit down into the epidemiology, you can see on the left figure the decreasing incidence of small cell lung cancer as a proportion of all cancers. It was 15 to 18% historically and is down to about 10%. And then on the right-hand side, you can see that there used to be a big difference between men and women presenting with small cell lung cancer, and that gap between them has closed in recent years. And both of these we think are due to changes in smoking, mostly a decline overall in smoking rates. Here's stage of presentation, and I found a nice illustration in this study that showed the proportion of patients being diagnosed with either extensive or limited stage relative to when we maybe had the technology to best detect it. So you can see around 2010, when PET was more commonly implemented, suddenly we were able to have better detection of extensive stage lung cancer. And this is one estimate. Many estimates range from about 3/4 to 85% presenting as extensive stage, but I found this to be a really helpful visual. Next slide. Finally, something that we should always talk about with small cell lung cancer when you're talking about kind of clinical clues for could this be small cell lung cancer is any patient who's presenting with a possible paraneoplastic syndrome for whom also has imaging consistent with maybe lung cancer, lung nodule, lung mass, mediastinal adenopathy, we should be really thinking about small cell lung cancer. It's the most common type of lung cancer to present with paraneoplastic syndromes. The two most common would be SIADH, which would have hyponatremia and most commonly present with neurologic problems. And then the next would be one of the myasthenic syndromes listed here. But you can kind of get a sense looking at this nice graphic from this review that most of the paraneoplastic syndromes, including the rare ones, have these neurologic findings. So if you're having those neurologic findings and no clear focal lesion in the brain on an MRI, for instance, because certainly we should be concerned about metastatic disease as well, and very at presentation for small cell lung cancer, then it should really pique your interest of maybe this being paraneoplastic and maybe this whole thing is due to small cell. Next slide.
Yeah, before we go on to the next slide, Adam, I would say two things. One is I always tell the pulmonary fellows in training, if you have to answer a question about paraneoplastic syndromes on the boards, whichever one they throw out, other than one, is going to be small cell. And they love to throw out Eaton, Lambert, and the others. The second point I'd make is treating the disease itself, treating the small cell itself sometimes can overcome these symptoms. So don't give up on the patient just because they have a paraneoplastic syndrome. Treatment can help alleviate the symptoms related to the paraneoplastic syndromes. And finally, the one paraneoplastic syndrome that's not associated with a small cell is hypercalcemia related to squamous cell carcinoma as a paraneoplastic syndrome. So if you had to pick one there, it would be squamous. The rest are going to be related to small cell.
Excellent points. Back to our patient case. This patient was seen within a week of that receiving that second opinion referral, and a biopsy was performed just 1 week later. Because the urgency was very clear, especially with that growth on imaging. So we tried to get that done as quickly as possible. A bronchoscopy with EBUS was performed. The 4R lymph node station was sampled, and no evidence of malignancy was found. And all the other lymph node stations either had absent tissue or were too small for biopsy. The mass was biopsied and found to have small cell lung cancer. As part of our practice, we also helped arrange the completion of her staging scans with an MRI brain, which showed no metastatic disease. Next slide. So just the briefest of overviews of neuroendocrine tumors of the lung. The top here are these carcinoid tumors, the most common of which is the typical carcinoid tumor. These have a less association with smoking. They're often very round, very smooth, slow growing. They're often associated with airways. So proximal airways or endobronchial disease is common too. And those often are incidentally detected, or if they invade airways and bleed, for instance, they get detected that way as well. Atypical carcinoids, tumors are more aggressive, but less common. And then of the neuroendocrine carcinomas, of which you could subdivide into large and small cell. Small cell, of course, is the focus of today's talk. Large cell, well, basically the cells are larger when they look at it under the microscope, and they're still of a neuroendocrine variety. They're treated a little bit differently, kind of a little bit more like the non-small cell variety, and those are also quite rare. And then the kind of other end of the spectrum, perhaps, would be diffuse idiopathic neuroendocrine cell neoplasia, which most of us would just call DIPNIC. And that has a very different constellation of usually multiple varying size nodules with either a ground glass or mosaic attenuation, and it usually presents with features like asthma with chronic cough and maybe even be diagnosed with asthma for a while before imaging. Um, and so this is kind of the spectrum of things we see for neuroendocrine tumors. On the right-hand side of this slide, you can see some of the features that help narrow this down to small cell lung cancer. Certainly, all of this is in the context of the radiographic and clinical things we spoke about, but importantly, the cells are small. That's one of the features that they'll tell you, even on site at bronchoscopy. And then they're looking for these other cytoplasmic and nuclear features. They're looking for a high mitotic rate. And then the staining is quite supportive. There's neuroendocrine immunohistochemical stains they can do, the lung marker stain, and then a Ki-67 stain is usually high. And those are all supporting features for this diagnosis. Next slide. So finally, we have a patient with staging scans. We have a diagnosis. We need to put all this together for our treating partners here. And so when it comes to staging, of course directs treatment. And there's kind of two staging systems for small cell lung cancer. The TNM staging just had its update in January of this year to its 9th edition or version. And really that system applies to both non-small cell and small cell lung cancer. But on the right-hand side, we have this limited and extensive stage division, and that might be more common and at least anecdotally more commonly used. And it's because how useful it is that if you can put someone in limited or extensive, that it helps with the treatment paradigm. And really, the cutoff here, we'll turn over to Dr. Singh to help us with this a little bit, because the cutoff between limited and extensive stage small cell lung cancer really depends on what might fit into a radiation port, they might say, or into a radiation plan. So with that, Dr. Singh, I'll let you take over from here.
Thank you. So thanks, Adam, for that introduction. And what I would tell you is, at the end of the day, it really comes down to what the radiation oncologist is able to feel comfortable treating. But there are systems that help take some of the mystery out of it. And so if you look over at the 1973 VA lung cancer study group, you see in blue, that would be the acceptable radiation port. In the 1989 IASLC staging system, you see that area is very expanded and includes a little bit of an effusion coverage, right? And in the 2010 AJCC system, you see that now you're going into the contralateral lung, but no longer treating the effusion. Where this really becomes important is understanding prospective clinical trials, because they will often use one of these particular definitions. And so you can use this to compare what were the allowed treatments across fields. And obviously, the definition of extensive stage doesn't fit in one of these fields. And there are some unique variations where it might fit in a radiation port, but according to the AJCC, it still counts as extensive stage. And this is where in clinical practice, your radiation oncologist may feel that that area can be covered, but the AJCC feels that the biology of those diseases does not go with extensive stage, or does go with extensive stage. Next slide.
And Arnold, before I go to the next slide, we saw before that Adam talked about the fact that limited was about 30%, 25 to 30%, and extensive is 70 or so percent. Is that what you see in your practice? That the B, C, or D, depends on what you're looking at, is about 30% of the time you find patients that fit into that paradigm?
Yeah, 30% or lower in Buffalo.
Okay.
And radiation hasn't been static over these many decades. So back in 1980, you see over on the left-hand panel, those were radiation ports. You would take an X-ray, AP, PA, or lateral, and you would draw with a wax pen, and that would be your field. Later, we started incorporating CT imaging, and we called that three-dimensional conformal radiation therapy. You're still treating the target, but now you can come at various angles. In all of those systems, the daily dose is, between 1.5 to 2 gray per day, 6 to 7 weeks, 60 to 70 gray, or twice daily with 1.5 gray and 3 weeks to a total dose of 45 gray. Over on the right-hand side, you have what we're currently doing, which is called intensity modulated radiation therapy. And this is a Medicare definition. So here you've taken the radiation oncology and team out of the planning process. And what the radiation oncologist is now doing is simply defining the volumes and the normal anatomy. Then the computer inversely plans and selects the optimal way to deliver the dose. So it's literally millions of little beamlets that are being delivered and painting a picture of dose onto this virtual anatomy that is then delivered onto the patient. Next slide.
Out of curiosity, have there been studies comparing 3D to IMRT directly?
Yeah, so there have been studies in a variety of sites. And what you find is that by lowering the normal tissue radiation, you can actually decrease side effects. And so what you can deliver safely changes. And in certain cases, you might be able to treat tumors that you couldn't treat with 3D or 2D radiation. And you can imagine that this is a very complex system, and now you're taking a lot of things into account, not just the dose delivered to the tumor. And that's probably too much to take, to take a quick glance at and figure out if you're doing things correctly or not, unlike the 1980s. And so what you have to do is you have to have these tables that show you what are the various targets and normal tissues getting, and do they meet the acceptable constraints? And so when everything passes, then you know that you've got a good plan. If things don't pass, then you've either got to redo the plan, or the radiation oncologist has to make a call about whether the trade-offs are acceptable or not. Next slide. So let's take a look at some of the studies that have been define the dose in radiation. So we start with the intergroup study on the left, and there they compared 2 radiation doses, 45 gray using single dose per day, or 45 gray using twice daily. In each case, in each of these studies, it was platinum etoposide for 4 to 6 cycles. The start of RT came at either cycle 1 or 2. And what you see in the Teresi group is it was a very large volume that was irradiated. But what they found is that BID was better, even though it produced more esophagitis. Well, That was a very old study, now more than 30 years old at this point. And the convert trial was done in Europe. They used three-dimensional conformal radiation and treated a much smaller field. So here, all you were doing was the gross tumor and a margin. So tumor, lymph nodes, grossly involved, plus a little margin. And they compared 66 gray to 45 gray twice daily, and they found no difference. The recently published intergroup study looked at 70 gray in a daily fractionation scheme or 45 gray. They had 3D conformal or IMRT, and they went ahead and treated the ipsilateral hilar nodes, whether they were involved or not, in addition to the GTV and a margin, and they found no difference between the doses. So looking at the nuances of the study, I mean, they were designed to be superiority trials. So because they were negative, you can't say that they are exactly equivalent. But in practice, you can treat either once daily or twice daily. Next slide. And then this is just an example of comparing limited stage small cell outcomes with PDL1 less than 25% in non-small cell. And you see that these survival curves are remarkably similar. And so I know that many times we have this nihilism, particularly about the outcomes with small cell lung cancer. But in modern studies, it's not as different as one would think at first glance. Next slide.
Yeah, so before I get to that, I really want to hammer home this point among pulmonologists, right? So I think most pulmonologists, particularly because they may not separate limited from extensive stage small cell, sort of think small cell's the worst of the worst, and these patients don't do well no matter what you do. But if you have limited stage small cell, which maybe is up to as much as 30% of the presenting patients with small cell, you have about the same outcome as stage 3 lung cancer, for which we routinely refer to our medical oncology and radiation oncology colleagues. And so I want at least our pulmonary community to understand that the nihilism surrounding small cell, it really, it doesn't make as much sense to me as some other things in medicine. So for those with limited disease, we would love to make sure that people understand, first of all, they can give their patients some hope. Same hope we give our patients with stage 3 lung cancer. There are patients cured at around that 35% mark.
And we've talked thus far about conventional radiation, but are there other options? And so, we talk about scalpel or saber. So let me just define the term. Saber is stereotactic ablative body radiation therapy, also called stereotactic body radiation therapy. SBRT has a specific Medicare, Medicaid defined billing code. And so it needs to be 5 fractions or less. In a system not covered by CMS, you can call it SABR. And here, we talked about 6 to 7 weeks of treatment, 1.8 to 2 gray per day. Here, you're talking about 10 to 34 gray per day done in 1 to 5 days with a total dose of 34 to 50 gray. Next slide. And in practice, what that does is it does produce reasonable survival outcomes with limited toxicity. If you look at this study, even though those curves are not statistically different, it was inferior to the conventional arm, but not statistically significantly so. Next slide. And then oftentimes, surgery is not the first choice for small cell lung cancer for a variety of reasons, but sometimes they are incidentally found at the time of surgery. And what you can see here is that as you could expect, as the tumor stage increases, the survival decreases, but you can get reasonable survivals combining surgery with chemotherapy in what is now an older study. But there is data for patients who happen to find themselves in that situation at your tumor board. Next slide.
Yeah, I just before I turn it over to Miriam, I would just say it's always like the surprise to us. We have a pulmonary nodule for whatever reason that doesn't get biopsied. It's hot on PET. Everyone sees it growing and says, "Okay, well, let's take it directly to resection." So what I'm hearing from you and what we do in our tumor board is that we go ahead and we resect them, and then everyone throws their hands up and says, "Oh my gosh, that was small cell," and then we do refer them to Dr. Alexander at our place for treatment with chemotherapy. And I guess that's also the practice at Roswell Park. Is that correct?
Yes, absolutely.
Okay. Now I'm going to turn things over to Dr. Alexander, who's going to talk to us a bit about the management of small cell lung cancer limited disease.
Thanks for having me, Gerard. So just to summarize some of Dr. Singh's earlier slides, the overall management of small cell lung cancer, there is a small proportion of patients with limited stage small cell lung cancer that can get surgery. And then if they have no significant spread of their cancer, but we would certainly recommend some chemotherapy after this treatment and possibly some radiation as well if the lymph nodes are found to be involved during the time of surgery. However, the majority of time we use a combination of chemo and radiation and now have added consolidation immunotherapy, which I will go over in a few slides. Next slide. However, I just want to take a step back and go over some of the survival data between small cell lung cancer and compared to non-small cell lung cancer. So this graph is showing that if we find these small cell lung cancers earlier in the stage, the survival may not be so bad. You can see there it's sort of 25 to 70% maybe. But when we get to the later stages, unfortunately, less than 10% of people are alive after 5 years. Next slide. So chemotherapy certainly plays a role in the survival. In this study, looking at the benefit of no chemotherapy, which is that bottom line there, this is in all stages of small cell limited and extensive, versus adding more cycles of chemotherapy, they found that the more chemotherapy, the better survival, with about 4 to 6 cycles being like an optimal number. Next slide. So small cell lung cancer is one cancer where you can have an improvement in outcomes if we urgently treat symptomatic patients when they present to the hospital. So in this study, looking at patients in an ICU who were given chemotherapy, the most benefit, especially in the first 100 days after the ICU admission, was seen in patients who had newly diagnosed small cell lung cancer compared to non-small cell lung cancer or other cancers. Go to the next slide. Anecdotally, I've also had patients who've come to the ER and had to be intubated for respiratory distress. And, a few days after treatment with chemotherapy, their cancer dramatically shrank, and then they were extubated to, sometimes even room air. So I've had, good outcomes by urgently treating some of these patients. So until the Adriatic clinical trial, the benchmark of survival for small cell lung cancer, I would say one of the trials, which is more recent, is the CONVERT trial, which Dr. Singh mentioned. And this is a trial where the radiation was compared from daily dosing to BID. And the main point I want to make here is that the overall survival for the whole population at 5 years was found to be between 25 to 30%. If you go to the next slide.
Before I get to that slide, though, I do want to press home the point. We often see we're pulmonologists who also do critical care, and we often see these patients immediately come in and be urgently intubated, and then everyone says, well, they got this big lung mass and they have cancer. It looks like they have cancer. Should we just sort of withdraw support in these patients? But what I hear you saying, what I've seen in my own practice is, they can get an amazing response with chemotherapy and get off the ventilator. And even if their survival is not great, they have a chance to, be with their family and make decent decisions and have those decisions calmly made in the light of day rather than just, unable to communicate while they're on the ventilator. Is that what you were trying to also?
Yeah, I was even just to to hone in on the point, like the respiratory point as well, but sometimes even pain, right? So the chemotherapy in these situations can also be palliative for pain, immediate pain control. We've seen people who've, had dramatic pain improvement in some of these, in their chest pain and their shortness of breath with just a few days after chemotherapy. So I have seen that as well.
And that's usually occurs in a single cycle.
Yeah, in a single cycle. Yeah. So when I compare I was talking before about survival of small cell lung cancer with non-small cell lung cancer. So here the survival is much better. It can go between 25 to 90%. And the graphs on the right are mainly showing that the survival has improved in the post-immunotherapy era. So the next slide will show you that the benchmark for, I would say, early stage non-small cell lung cancer would be in the order of about 60% or higher at 5 years. And this is, I'm basing this on the Keynote 671 trial where we added immunotherapy to the surgical paradigm in non-small cell lung cancer. And so, I would say 60% is a good number to think about at 5 years. So if you go to the next slide, I want to point out that even in very small cell lung cancers, at stage 1, the 5-year survival is more in the order of 47%. And the graph on the right is showing that the addition of chemotherapy after surgery improves survival. So if you go to the next slide, I've done this all to kind of set up this Adriatic clinical trial where the addition of immunotherapy significantly improves survival. So this was the first study that showed that maintenance immunotherapy with a PD-L1 antibody called durvalumab after concurrent chemoradiation improved both progression-free survival and overall survival. So this trial was a phase 3 randomized double-blind placebo-controlled trial where 730 patients were randomized to durvalumab versus placebo after concurrent chemoradiation, as long as their cancer was stable or improved after that concurrent chemoradiation. The patients, and if you go to the next slide, we can see that the patients on the durvalumab arm experienced about a 2-year prolongation in overall survival compared to placebo, with a median overall survival of 55.9 months in the durvalumab arm versus 33.4 months in the placebo arm. So when specific subgroups were looked at, there was benefit seen regardless of stage, prophylactic cranial radiation, chemotherapy regimen, frequency of the radiation, and the timing of starting the durvalumab. So this makes this the new standard of care, with the FDA approving this in December of 2024 for all patients after completion of concurrent chemoradiation and that have not shown disease progression. So if you go to the next slide, you can see that it's actually part of our NCCN guidelines and is a Category 1 recommendation for limited stage small cell lung cancer. And so now we'll go back to Dr. Singh to discuss PCI.
And before we get there, Mariam, like I've been at this for 30 years, and this is like the first new big breakthrough in treatment, right? Like we've been waiting for something like this. And before we go to Dr. Singh, could you just mention briefly that there's a lot, just we've seen this explosion in the treatment of non-small cell, basically targeted therapies and immunotherapy. Are we starting to see some action in the small cell space? And is this going to be the only thing we look at, or are you thinking that there's going to be this, waterfall of new things coming at us?
I think there is going to be a waterfall of new things coming at us. What we are doing, the way these drugs develop is basically we have them in extensive stage small cell, and then we kind of try to move it into the limited stage setting. So immunotherapy, we'll see in the next webinar, has been approved for extensive stage for a few years now. And, we've all been waiting to use it for limited stage as well, especially because we use it all the time for non-small cell lung cancer. So there are a lot of other drugs being developed for extensive stage, and we are running several of these trials even at our institution for limited stage small cell lung cancer as well, combining different immunotherapies and adding things, to the immunotherapy. And so sometimes even pills and, small molecules as well. So I am expecting an avalanche of approvals in the next few years.
All right. And we're going to go back to Dr. Singh, to talk to us a little bit about prophylactic cranial irradiation, which has been something that there's been a bit of controversy over time, and that we've seen it come and go, and we want to know where it is, Dr. Singh.
So that's great. We had several trials from 1995 to 98 that looked at PCI versus no PCI and didn't show any significant differences. And then a meta-analysis came out in 1999 and showed that there was a 5% survival benefit that was statistically significant. And the incidence of brain metastases in the PCI population was about halved. What is interesting is that neurocognitive dysfunction was looked at earlier in the earlier trials in a couple of them, and there was no difference between arms. So it makes you question exactly how they were looking at it. So that's 1999. Things have changed a little bit in the landscape since. So let's look at the next slide. So things to keep in mind. There was no MRI. Some of these patients were even in the pre-CT scan era. The incidence of brain mets when you do a CT scan is about 10%, and when you do an MRI is 24%, with only half being symptomatic. And then there is staging drift. So PCI only benefited those patients who did not have a PET scan. So you've had all of these imaging advances over time that have really changed the population and potentially changed the background of what the PCI was achieving. So today, next slide. I think we can go on to Adam, and then I'll make my final point.
Yeah, before we hit Adam, though, so I do want to ask you, though, right now, from what Miriam tells us and what you've told us, a patient comes in with limited stage small cell lung cancer. They'll receive chemotherapy and radiation, and if they have a complete response, right now they would get immunotherapy as a maintenance, and that maintenance would be for a year or more than a year.
It's 2 years.
2 years, okay. And then we'll talk again, I guess, about whether or not the patient would get PCI
Right.
at your institution or at other institutions, or is that a bigger, longer discussion with the patient?
No, so it's a bigger, longer discussion with the patient. If they're going for immunotherapy, PCI was allowed on that trial. And so those patients who are getting immunotherapy would still be eligible for PCI. The interaction wasn't great, and so you'd have to look at you'd have to talk to the patient and have a thorough discussion about whether or not to do the PCI. I think right now, again, it varies by institution, but at our institution, less than 5% of the patients end up getting PCI.
And I think you've mentioned to me in other arenas that one of the other possibilities is that if they have a great response, you don't want to have those patients get neurocognitive dysfunction. But also, if you got an MRI and they had symptoms, you could do stereotactic brain radiotherapy in those instances. Is that something that you entertain routinely in your place?
Yes, absolutely. And so there are ongoing clinical trials that look at this issue and actually randomize patients. And in the absence of those clinical trials, our institutional practice is to favor expectant management with stereotactic radiation when necessary.
All right. Well, I'm going to turn it back over to Adam. And Adam, why don't you continue? You're on mute, sir.
Thank you, Gerard. I just have a short bit here. This is the conclusion to our case. This patient started their regimen of chemotherapy and radiation therapy just about 12 days after the diagnosis was made on pathology, with an excellent response. continued on immunotherapy afterwards. And this image is from a year later, where you can kind of see where some of these likely just radiation changes where this mass used to be. And so currently, based off of available imaging, we're at about a year and currently no evidence of disease.
So I want to go back now and just revisit everything we've learned. One of the things, though, I'd like to ask Maren before we go back is, for our pulmonary audience, one thing that we do when we do EBUS is take specimens for mutational analysis. And we've been trying to make sure we educate our pulmonary population that this is hugely important in non-small cell lung cancer. And while there are many studies showing that it only takes 3 passes during an EBUS to make an adequate diagnosis, we need more like 6 passes for mutational analysis or NGS testing. Is there any... Right now, based on what I'm hearing from you, is there any reason now or in the future for us to be starting to think about taking a lot more specimens or to store for analysis in the future in patients with limited stage small cell lung cancer?
That's actually a tough question because as an oncologist, I always want more tissue for many reasons, either to make a proper diagnosis, but also for research purposes and to archive these tissues for future needs if a patient needs to be on a clinical trial and other things. But in terms of just the difference between using biomarkers in non-small cell lung cancer versus small cell lung cancer, traditional biomarkers of, say, immunotherapy response, for example, that we use for non-small cell lung cancer, which is PD-L1 expression. When we looked at that in small cell lung cancer, it did not correlate with the benefit of immunotherapy. So that means that regardless of your PD-L1 expression, there was some benefit to adding immunotherapy to the chemotherapy, at least for extensive stage small cell that they've looked at. In terms of where the molecular kind of field is going in small cell lung cancer is more about getting these transcriptome and proteomic profiles, because what we are finding is 4 kind of different categories of small cell. So we feel like we're actually dealing with 4 different cancers based on their neuroendocrine subtypes, but also their immune gene signatures. So I think in the future, it's not prime time for clinic, but if we had more tissue and, if this helped guide what future therapy would be available for this patient, it would be beneficial to have more tissue.
Great. That's fantastic.
Gerard, I'll chime in if you don't mind. Most pulmonologists who are arranging these biopsies, often for small cell, especially with these central tumors, are going to be performing the bronchoscopy and biopsy, probably using EBUS in most of those cases. And many physicians and patients aren't going to have access to ROSE or rapid on-site evaluation. So most people should plan to get biomarker testing for all the bronchoscopies they do. One, because non-small cell is much more common, and those biomarkers are essential to treating across almost all the stages of non-small cell now. And even if you do have rapid on-site, that's still just a preliminary read. I'm sure everyone who has that have been told time and time again by their pathology colleagues, hey, this is just us trying to help out to tell you if you're getting lesion or not. We're not really making a diagnosis for sure here. So the take home should be biomarkers is essential to be doing any planning when you think you're diagnosed with lung cancer, of course. And that probably doesn't change with this small cell. It just ends up so right now it's not essential on the back end at this time.
So I'm going to take the chair's prerogative and answer Lila's question. Was the case presented during the multidisciplinary team meeting? And I'll let Adam answer that since it was his case, but then I'll chime in and ask for our other speakers to respond as well. Adam?
Yeah, absolutely. This case was presented both in and outside of multidisciplinary team meetings. I can almost assure that I at the time of preliminary diagnosis, got advice from our radiation oncologist, who I think is just leaving, and from Dr. Alexander at the time. And I can't remember any patient that I've diagnosed with small cell lung cancer that I've not put on our tumor board in recent past. And it's just so we can get everyone together at the same time to review these images and available results and try to expedite the care. But that's also why I reach out even before those meetings to people like Miriam and our radiation oncologist locally to get that opinion on how to get them in as quickly as possible.
Yeah, totally agree. I'm going to ask people to put in their questions into the chat. And while I finish up with this, so the first thing I think we should all recognize is that over the past few decades, the amount of small cell has decreased, as is, by the way, the amount of squamous cell carcinoma in our histologic proportions in lung cancer. But it still represents about 10%. And one thing we talked about before this webinar is the fact that it does seem to come in like little patches, right? Like you won't see a small cell for a few months and then 3 will come up in the same week. And so you got to be cognizant of that. The second thing is it grows quickly, so speed is really important. It's a central tumor with usually some lymphadenopathy. Getting the staging done, the MRI of the brain, the diagnosis, the PET scan should occur as simultaneously as possible. And in our place, and I know everyone is not as lucky, we have an incredible nurse navigator who helps tie this all together. And so that's really, really important. And then we think that having that multidisciplinary conversations is essential, so that right in the first meeting of our multidisciplinary tumor board, we can go ahead and say, hey, look, like this is a small cell. Do we think it's limited or extensive? We ask our radiation oncologist, can we get it all in one port? When are we going to start treatment and get things moving quickly? So that's another aspect of this. We did talk about prophylactic radiation, cranial irradiation versus surveillance MRI, and I think we heard from Dr. Singh that in his institution, I think in our institution, prophylactic cranial irradiation is being done less and less, though we do discuss that with our patients. And honestly, immunotherapy has been the first of all of these advancements that we've seen in a very long time, which kind of excites us because we've been frustrated with all of the breakthroughs in lung cancer, but we've seen so many great breakthroughs in the last 5 years, 5 to 8 years in non-small cell lung cancer than we have in the past. So Sharif has a question for the group. How about dual histology, small cell, non-small cell? Do you treat it as small cell, and which is the worst prognosis? I'm going to put that to Miriam there for her consideration.
Yeah. Thanks for that question. We do see the combined small cell, non-small cell, not very often, but we've seen it enough. Definitely would be differing for the urgent treatment to the small cell regimens and involving our radiation colleagues if it's limited stage. But this is a case where biomarker testing would be absolutely required, because for that non-small cell component, you never know if there's a molecular alteration or a driver that we could possibly add to our chemotherapy, or even in the maintenance setting, add it a little bit later. The other thing I wanted to mention here is the EGFR lung cancer, non-small cell lung cancer, can transform into small cell lung cancer. We don't see that as often in the Western population, but the Asian population, where there is a higher prevalence, up to 50 to 60% of non-small cell lung cancers can actually be EGFR positive. They can present as de novo small cell. And so there are a lot of studies not a lot of studies, but there are studies looking at adding the EGFR inhibitor to the chemotherapy, and at least keeping that EGFR inhibitor in the maintenance setting. So to answer your question, in the acute setting, you want to treat it like small cell, where you're using regimens that would have efficacy for small cell lung cancer, but you certainly want to be cognizant of that non-small cell component as well.
And I just wanted to jump in very briefly. The chemo RT coordination is so key because especially if the medical oncologist can initiate the chemotherapy quickly, and we can give a cycle that gives us time to plan the radiation in the fancy IMRT way that I had described, and that's probably going to be better for the patient in terms of side effects.
Great, thank you. This next question's tough, but I'm going to take the first stab at it and then turn it over. So it says with robotic bronchoscopy, we were finding co-synchronous or multiple primary lung cancers in the same case at the same time, right? Let's ignore for a second. Let's ignore for a second what the histologies of those are. But I would agree we are seeing more of these several tumors in the same patient. And do you have any recommendations on adequate or appropriate staging as we do our tumor board and spend a lot of time in these cases? So I guess the first part for me is I want to make sure that unless it's overwhelming evidence that there's a big primary and multiple mets from the same cancer, if it's, let's say, two nodules, I want to put on blinders and evaluate each of those independently, right? So that, it might be two synchronous primary non-small cell lung cancers. And so I try to look at those and really focus on each one individually. If we have biopsy proven two different histologic types, that makes it even easier. You have two stage ones, for example. I don't know the last time I've ever seen a case where I've had small cell and non-small cell in the same patient at the same time. And so I'm going to turn that over to ask Adam or Miriam or Anu if they've seen that.
So I agree with you completely. I think that you have to look at each of these tumors independently and together. And if you have any time course, the radiology review in a multidisciplinary way of how are these acting, are they behaving similarly or different? And then we commonly end up sending molecular on both of those biopsies to see how close they are. Our molecular pathologists will often talk about shared mutations on that molecular analysis or discrepancies in those mutations to try to see whether or not they seem to have a common origin. And then I would say for almost any case where there's multiple concerning nodules, I would say universally they all have mediastinal staging with EBUS at the time of robotic bronchoscopy, or even if there is no robotic bronchoscopy, mediastinal staging. I think I can remember the last one, and of course a PET scan to look for other sites of distant disease. In terms of the only case I remember with small cell and non-small cell, I've shared with Miriam Alexander. I'm pretty sure it may have even just been her patient, to be honest, at tumor board. So I'll also let Miriam take that part of the question too.
Yeah, I remember I had a few cases where but it's in the kind of in the same specimen, right? Like it's not where it's in different nodules. In the same specimen, you get a combined small cell component in that sea of non-small cell. I have had metachronous non-small cell and small cell, like not at the same time, but in the same patient who unfortunately I don't know if it's related to the smoking but has continued to smoke and things like that, have had multiple cancers and has had a couple of non-small cells and then had a small cell. So in that way, I've had those types of issues as well.
Yeah, and I just want to add one thing to Adam's, where you're evaluating two different lesions in the same patient. We take a lot of different evidence, growth patterns, what it looks like if one's spiculated, one's not, if both are spiculated. Also, sometimes PET avidity can give you some clues. So you might have one that's a dominant nodule with really, really hot on PET and the other not so much. And sometimes we treat the first one that we think is the sort of more dangerous one, if you will, and keep following the other smaller nodule that might not be PET avid because we think they might be two different histologies. I have one more question from Sharif, and thank you for this question. If we get pure small cell on rows in the Bronx suite, do we send anything for biomarkers? I want to preface this by saying I'm going to give it to Adam for a second. We have reflex testing in our institution now, whereby if it's a non-small cell and it gets to a pathologist and it's noted to be non-small cell, it gets the full 50 gene panel of testing plus PD-L1. If it's small cell, I wouldn't take just what Rose says on that in the bronch lab. I'd wait till it gets to the pathology lab and see what they say. And if it does come out to true small cell, Adam, we don't generally test after that. Is that correct?
That's correct. Our pathologists are completely on board with that. We have a kind of a coordinated system across pathology and all of our clinical thoracic oncology. So we've all kind of gotten together. We've kind of laid out for what stage, what histology, et cetera, we would like testing to be performed. And we're fortunate to have a really supportive pathology group. And we've all agreed that for the non-small cell histology, or very poorly differentiated histology, kind of suspicious for non-small cell, that the pathologist help initiate that testing directly, but not for small cell, at least at this time. We'll see in the future if there's any testing that needs to be done, but at this time that is not reflex, so to speak, for biomarker testing. And because of that, none or very infrequently now do we order biomarker testing from the bronch suite. Really, we have this agreement with radiology to, once they're kind of done doing the work, to go ahead and work on molecular testing.
You meant to say pathology. You said radiology, but yes, you meant.
Oh, sorry.
All right. Well, listen, we're coming to the end of the program here. I'm going to give each of you a last word. Anything you want to say about limited stage small cell? You can go first, Anu.
Yeah, so it's really the multidisciplinary tumor. It requires an urgency and a coordination that maybe some other tumor types don't require as urgently.
Okay, and Adam?
I would say, having that one already been taken, I guess I would say that the big difference for me is how frequently the staging is a little bit out of my hands, and that I've got to call Anu up and say, hey, can you take a look at what we have so far on CT and PET, and try to get it to that multi-D meeting, after our discussion, to get everyone on board.
Is that to see whether he can fit it in the radiation field? Is that what?
Yeah, as to helping determination of stage. Yeah.
Okay. And Miriam, last but not least.
Yeah, I think I want to reiterate Anu's excellent point about the multidisciplinary, but also the expedited workup. Because if you wait a few weeks and, if a PET is delayed or something like that, could turn extensive. So, it is, and we're changing the overall prognosis for the patient. And also, in addition to multi-D, also just making sure the patient has an understanding of their options, right? And so they will have to meet radiation as well as med-onc to hear these options. So not making any assumptions here, and at least giving that chance of having somebody discuss the options with them.
And I want to end on a note of optimism. We have seen in the last 5 to 8 years incredible advances in non-small cell lung cancer. If someone has an ALK rearrangement and metastatic non-small cell lung cancer, we are routinely seeing them live 5 years. That was unheard of. It used to be 9 months and almost everyone was gone. I feel like we're on the cusp with small cell lung cancer, even just with this first advance, which is to use immunotherapy with these patients, that we're on the cusp of seeing really, really better and better and better outcomes. And it requires us to be a team. And the one great thing about being a pulmonologist, we work in ICUs in teams, we work in our clinics in teams, but we really need to work in our cancer center in a team with our friends in medical oncology, radiotherapy, pathology, and radiology. So with that, I really want to thank the speakers today for putting together some outstanding slides and talks, and I appreciate everyone's kind attention. Thank you very much.